Hi, this is Susan Wiggers. I'm a professor of medicine at Temple University School of Medicine, and I'm going to discuss the normal transthoracic echocardiogram. These slides were made in association with my colleague at Temple, Dr. Martin Kane. The standard views for a transthoracic echocardiogram are named for the location of the transducer, and you'll see them listed here below. We'll go over them. In the parasternal long axis view, the transducer is placed on the chest wall in the left parasternal area, and the heart is imaged in long axis. Here you can see a cartoon of what is visualized and an actual 2D transthoracic echo. The tip of the triangle is always at the transducer, so we see here looking at the arrow, the chest wall, the RV free wall, the RV cavity, the interventricular septum, the LV cavity, and the inferolateral wall. This is the anterior leaflet of the mitral valve and the posterior leaflet of the mitral valve. The aortic valve is here and the aortic root here. This is the left atrium. You'll notice that the mitral valve is closed and the aortic valve is open, so this is a systolic frame. The descending thoracic aorta is visualized posterior to the left atrium. Here's a moving image of what I just showed you. Again, the descending thoracic aorta. Note the normal motion of the mitral valve, and less clearly seen, but also normal, the aortic valve. The portion of the RV that's imaged in the parasternal long axis is actually the RV outflow tract and not the body of the right ventricle itself. Other structures can be imaged from this view. The coronary sinus is seen only when it is dilated, and here we see a dilated coronary sinus in the posterior AV groove. And again, the descending thoracic aorta. The right coronary artery is seen here arising from the right sinus of Valsalva. And now you can see that this is a diastolic frame with the mitral valve opened and the aortic valve closed. If the transducer is moved one interspace cranially, the ascending aorta can be visualized. This is an excellent view for measuring not only the aortic root, seen here, the sinotubular junction, and the proximal ascending aorta. The left atrium, again, is seen posterior to the aorta, and the very high RV outflow tract here anterior to the aorta. Now, M-mode is still done in many labs. It is multiple pulses are sent out along a single line. The advantage of M-mode is that it has very high temporal resolution, and previously it was the standard for measurement of chamber sizes. When making M-mode measurements, it's important to be made from the parasternal long axis and not the short axis, and I'll show you why in just a moment. The measurements are made by convention from leading edge to leading edge. And when measuring the interventricular septum, it's important to avoid RV trabeculations. Now, this is an M-mode. We see the 2D up here, and the M-mode is directed through the aortic valve and the left atrium. So here we see time on the y-axis and distance from the transducer on the x-axis. This is the motion of a single point and a single line through the heart. We can see here the anterior aortic root, the aortic valve. This is the right coronary cusp that moves anteriorly and systole, and then the coaptation point in the middle of the aortic root, and the left atrium posterior to the aortic root. At the level of the mitral valve, we see the motion of the interventricular septum as well as the normal motion of the mitral valve. These openings are named the E and the F wave. They do correspond to the E wave and the A wave that we'll talk about on Doppler, but obviously they're very different things. We're not measuring velocity of blood flow. We're measuring opening distance of the mitral valve from its coaptation point. Now, here we see an example of M-mode measurements measured from the parasternal short axis view, which we'll get to in a minute. But it's important to note that it's hard to tell whether you are measuring the real LV cavity or whether you're oblique and measuring too large an LV cavity. But here we see the measurements of the interventricular septum, the LV cavity, and the posterior wall, as well as the LV dimension in systole. But far more labs are making measurements from 2D images now, frozen 2D images. We measure the LV cavity at the parasternal long axis at the chordal level at end diastole. End diastole is judged by the motion of the mitral valve and the size of the LV cavity rather than the EKG, which is usually displayed at the bottom of the picture, but can lag the exact timing of end diastole. 2D measurements are made from trailing edge to leading edge, and so necessarily 2D measurements are smaller than M-mode measurements. In fact, the upper limit of normal for an LV end diastolic measurement is 5.2 centimeters, and an M-mode is 5.5 centimeters. The LV wall thickness is measured again also at end diastole. Here's an example of 2D measurements made at end diastole. Notice that the EKG cursor really, in this case, corresponds to the exact measurement, but to the exact timing of the end diastolic frame. But this frame was picked by the first frame in which the mitral valve is shut and the LV cavity is at its largest. The measurement is made from trailing edge to leading edge, and the measurement here is 5.4 centimeters. Here is the systolic measurement in a different patient, and again, the frame is picked by the smallest LV dimension rather than any EKG timing down here. Now let's move on to the parasternal RV inflow view. From the parasternal long axis view, the transducer is directed medially and caudally towards the feet. This is the only view in which the posterior leaflet of the tricuspid valve is seen. TR is visualized, but it's usually not the best place to measure the peak velocity, and IVC inflow is seen. Here is an example of a patient with an abnormal tricuspid valve, but this is the anterior leaflet of the tricuspid valve. This is the posterior leaflet, and IVC inflow is here. This is the right atrium, and this is the right ventricle. In these moving transthoracic RV inflow views, you can see that the anterior leaflet and the posterior leaflet coap nicely. We see the RV cavity. This is not a view in which to judge the size of the RV cavity as it's off-axis. And we can see very vigorous inflow on the color image from the inferior vena cava. There's a little flow here from the coronary sinus. And you'll notice that in systole, there's a very trace amount of tricuspid regurgitation. I want to emphasize that the views of the pulmonary valve, again, are named for the transducer position and not for what you see in these images. And so let's look first at the parasternal long axis view of the pulmonary valve. The transducer from the back to the parasternal long axis view of the LV, is directed medially and cranially to get a view of the pulmonary artery and the pulmonic valve. This is high RV outflow tract, and this is the pulmonary valve and then the pulmonary artery. This is a great view for looking at the pulmonary valve and making sure that the motion is entirely normal. Not such a great view for looking at the pulmonary artery. We'll see a better view in a minute. And this is a view here looking again in the same view. We can see in diastole this jet of pulmonic regurgitation, which is trivial and in fact seen in 80 to 90% of people. This is a zoom of the pulmonic valve, and again we see the motion of the valve opening in systole and closing in diastole. The pressure in the pulmonary artery is very low and is near the pressure of the right ventricle in diastole, or certainly closer than is the case for the aorta and the left ventricle. So it's normal for there to be presystolic motion of the pulmonic valve after the atrial kick, moving the valve towards the pulmonary artery. And then the valve opens in systole and closes in diastole, stays closed, and then again, presystolic motion of the pulmonic valve. And this is entirely normal. Now, the parasternal short axis view at the base of the heart can show us many important structures. Here in this cartoon, we see that at the parasternal short axis at the base of the heart at the aortic valve level, we're looking at the three cusps of the aortic valve. We do see the pulmonary valve. Remember that the right heart wraps around the left heart at all levels, and so here we see intraatrial septum, a portion of the right atrium, the septal leaflet of the tricuspid valve, the high RV outflow tract, and the pulmonary valve. Here's an example of that. The right coronary cusp is the most anterior cusp of the aortic valve, and the non-coronary cusp is intersected, seen best here, by the intraatrial septum. That leaves this as the left coronary cusp. The left atrium is posterior to the aorta, and this is the left atrial appendage. This is the normal view of an aortic valve in systole. Note the triangular shape of the opening, and this is a normal aortic valve. And here we see just normal aortic valve and normal color. We can see small jets of aortic regurgitation in this view, but it's not the best view for measuring aortic regurgitation. If the transducer is moved slightly medially, the parasternal short axis view of the pulmonary artery can be seen. Here is the aortic root. The pulmonic valve level is here. This patient has a dilated main pulmonary artery. The right pulmonary artery passes posterior to the aorta. This is the left PA. They're often not in the same plane, and the transducer has to be angled to see both pulmonary artery branches. And again, this is the parasternal short axis view in which you see the pulmonary artery and long axis. This is the optimal view for obtaining velocities by pulse wave Doppler. Here you can see that the sample volume has been placed in the middle of the main pulmonary artery. In an adult, the normal velocity is 0.8 meters per second. This patient was actually pregnant and so had a higher cardiac output, and the pulmonary artery velocity is higher. almost 1.3 meters per second, which reflects the higher flow. If the transducer is moved in the other direction towards the RV, we see the tricuspid valve. This is the aortic valve here. This is the left atrium, the interatrial septum. And here we see the right atrium, inferior vena cava flow, and this flow along the septum is the superior vena cava flow, and here is the tricuspid valve. This is a good view for lining up with a tricuspid regurgitation jet to measure true velocities. At the short axis, as we move down the transducer down towards the apex of the heart, we can image the left ventricle, and here we're looking at the left ventricle at the level of the papillary muscles. And we can see both papillary muscles here, the posterior medial papillary muscle and the anterior papillary muscle. This is the inferior wall. This is the septum, and this is the anterior wall, the lateral wall, and the inferolateral wall. This bright structure here is the diaphragm. It is standard to record views of the left ventricle and short axis at the level of the mitral valve, at the level of the papillary muscles, and then at the level of the apex. The ventricle should be round and circular in a normal patient. If you see an oblong shape, that means you're off axis and need to rotate the transducer. At the apical view, you shouldn't see the papillary muscles. You'll see that in one frame of this. We do see the papillary muscles, and then the transducer is moved more towards the apex, and we get a true apical view. In this mitral valve view, we see the anterior leaflet of the mitral valve and the posterior leaflet of the mitral valve as they open in diastole and close in systole. Moving on to the apical views, there are three standard views, and the first is the apical four-chamber view. This is in the standard presentation with the left ventricle to the right of the image and the right ventricle over here. This is the lateral wall and the inferolateral septum, the left atrium, the anterior leaflet of the mitral valve, and the posterior leaflet. This is the septal leaflet of the tricuspid valve and the anterior leaflet of the tricuspid valve, the right atrium, the right ventricle, and the descending thoracic aorta here, posterior to the left atrium. There are two ways to distinguish left ventricles from right ventricles. This is important in patients with congenital heart disease. You can see, first of all, that the tricuspid valve is placed more apically than the mitral valve. And many patients have a moderator band, not seen so well here, but runs from the septum to the RV free wall, and there is no similar structure in the left ventricle. And so the placement of the tricuspid valve and the presence of the moderator band distinguishes this as the right ventricle. One of the advantages of the apical four-chamber view is that we are aligned, really with all the apical views, is that we are aligned with the flow of the heart and so can get precise measurements of velocities. In the apical five-chamber view, the transducer is angled anteriorly from the four-chamber, bringing in a view of the aortic valve and normal flow into the aorta from the left ventricle in systole. It's important to remember that optimal 2D images are obtained when the ultrasound beam is perpendicular to a structure. That's why the parasternal long-axis view is really great for looking at cardiac structures. But the optimal Doppler interrogation occurs when the ultrasound beam is parallel to flow. That's why the parasternal long-axis view is not very good for measuring velocities and really even often for color flow Doppler. But the apical views allow alignment with most cardiac flows and are the place to measure velocities. There's more about this in the physics slide set, but color Doppler is a pulse wave modality and can't resolve high velocities. We often use a turbulence map that demonstrates velocity and direction as well as turbulence. Pulse wave is spectral Doppler shown by similar to what I showed you in the pulmonic valve, and continuous wave Doppler resolves high velocities but introduces a range ambiguity. It's not possible to say exactly where that peak velocity occurred. So here's an example of normal mitral inflow across the mitral valve. The sample volume is placed at the leaflet tips and not down in the left atrium. The EKG is here. Here's the baseline, so flow towards the transducer is positive, flow away from the transducer is negative. And as the mitral valve opens, we see early diastolic filling. There's then a short period of diastasis, and with the atrial contraction, the A wave occurs. Now remember, we saw a similar pattern on the M mode of the mitral valve in the parasternal long axis. And although the timing is the same for the E wave and the E wave of the M mode and the A wave of the Doppler and the F wave of the M mode, we're again measuring two very different things. Here we're measuring velocity in centimeters per second. You'll also notice that this is laminar flow, meaning that all of the blood vessels are moving at the modal velocity, indicated by there being no signal or not much of a signal here. All the red blood cells are moving in the same direction and at the same velocity, making this laminar flow and normal filling of the left ventricle. From the apical four-chamber view, you can also see three of the pulmonary veins, the two superior veins at the bottom. This is the right atrium, right ventricle, so obviously this is the right superior vein, and you can see the left superior and then the left inferior veins here. It's possible to get pulmonary vein flow by Doppler in about 70 to 80% of patients. The sample volume is placed about 1 centimeter down into the right superior pulmonary vein, and the normal flow shows systolic predominance. Most of the left atrial filling occurs during ventricular systole, and then smaller filling during diastole. Tissue Doppler has been added in many labs to the standard transthoracic exam. There are tissue Doppler settings that allow you to measure lower velocities and higher amplitudes than conventional Doppler blood flow. We use it to assess systolic and diastolic motion along a line parallel to the ultrasound beam, and you can display it in color or spectral. Here's a spectral display of tissue Doppler. The sample volume is put right on the septal side of the mitral annulus, and let's start in systole. The ventricle contracts, the mitral annulus moves apically, and so there is a velocity. This is measuring velocity again towards the transducer. This is 5 meters per second, 10 meters per second, so the normal systolic velocity in tissue Doppler for an LV is about 10 meters per second. And then in diastole, as the ventricle relaxes, the mitral annulus moves away from the transducer, away from the apex. And this is called E prime, and corresponds to the timing of the E wave on Doppler, and this is A prime, corresponding to the A wave on regular Doppler. This is 10 centimeters per second, and an E wave of 10 centimeters per second is entirely normal. You can also pulse the tricuspid valve, and the measurements are the same. We see that there's an E wave and then an A wave. There is normally some respiratory variation of the tricuspid valve velocities. You see one here. As the patient breathes, the velocity changes, but the variation in peak velocity shouldn't be more than 30%. In the apical 5-chamber view, we can measure LVOT velocity by placing the sample volume in the LVOT just proximal to the aortic valve. And again, that's in the apical 5-chamber view. Here, notice that the scale is quite different than the tissue Doppler. This is 40 centimeters per second. So a meter, this is 2 meters per second here, or 200 centimeters per second. And the velocity here in this patient in the LVOT is about 140 centimeters per second, or 1.4 meters per second. We also can put continuous wave across the aortic valve and measure peak velocity. We assume that the peak velocity comes right at the aortic valve orifice. This is done again from the apical 5-chamber view. This patient has a peak velocity over 2 meters per second, and they actually have some mild aortic stenosis. If the transducer is moved medially from the regular 4-chamber view, you get a more RV-dedicated apical view. Again, nice alignment with tricuspid regurgitation to measure true velocity of the tricuspid valve. We also measure something called TAPSE, or tricuspid annular plane systolic excursion. The M-mode cursor is put through the tricuspid valve annulus, and we see that in systole, the annulus moves apically and then moves away from the transducer in diastole. TAPSE is measured from the lowest point of the tricuspid annular excursion to the top, and you see here the measurement was made as 2.5 centimeters. Greater than 1.6 centimeters is considered normal. You can also place the Doppler, the tissue Doppler sample volume in the RV free wall and measure the velocity of motion of the RV free wall, and that normal measurement for the S prime wave is greater than 10 centimeters per second. Now, rotating the transducer from the apical 4-chamber, we reach the apical 2-chamber view. This view shows, again, the left atrium here, and the anterior wall and the inferior wall. This view, you can often see the left atrial appendage if it's enlarged. And here's an example. The anterior leaflet of the mitral valve, the posterior leaflet of the mitral valve, a little piece of the coronary sinus. It looks enlarged here, but it's actually cut a little oblong. It's running in the AV groove posterior to the left atrium. And again, we can see that this patient has very trivial mitral regurgitation, but we're lined up nicely to measure velocities as we're parallel to the velocities we're interested in here. Rotating the transducer further brings us to the apical long axis view. It's also called the apical three-chamber view, although apical long axis is preferred. This view is exactly the same as the parasternal long axis view. It's in the same plane, but the transducer is put at the apex here, while in the parasternal long axis view, the transducer is more over here. Again, from the apical long axis view, we're very well lined up with both aortic outflow and mitral inflow. This is the anterior septum. We can tell the difference between the anterior septum and the inferior septum because if you see the aortic valve, then you're seeing the anterior septum. And this is the infralateral wall. In some older publications, it's called the posterior wall, but the naming convention was changed probably about 6 or 7 years ago, and the preferred name here is the infralateral wall. And here's a nice view. Again, we see the aortic root, the anterior leaflet of the mitral valve. The posterior leaflet is here, although we don't see it well. And this is the descending thoracic aorta. Again, from the color Doppler, red flow towards the transducer, so mitral inflow, and then blue flow away during systole. This is normal color flow Doppler from the apical long axis view. Now, the subcostal views are very important to be able to obtain because they can save a technically limited study. The other views are obtained with the patient in the left lateral decubitus position, but the subcostal views are obtained with the patient supine. Sometimes it helps to have the patient flex their knees so that they loosen up their abdominal wall muscles. But pressure on the transducer may be very painful, so make sure you check with the patient rather than just staring at the images. But it often is the very best view for imaging an intubated patient. From the subcostal long axis view, the tip of the triangle is at the transducer, which is on the abdominal wall. So the first structure you see here is the liver. We then see the diaphragm, the right ventricle, the left ventricle, and the atria. So here in this subcostal four-chamber view, we see the lateral wall of the LV cavity, the inferior septum. Remember, no aorta, so it's the inferior septum. This is the anterior leaflet of the mitral valve, the posterior leaflet. Here's the right ventricle, the tricuspid valve, the anterior leaflet of the the septal leaflet of the tricuspid valve here, and the anterior leaflet over here. And we can see just the opening of the inferior vena cava into the right atrium, and we also see some hepatic veins as the patient breathes and we move through the view. A short axis of the left ventricle can also be obtained from the subcostal view just by rotating the transducer 90 degrees from the four-chamber view. Again, here we see the liver and the right ventricle. This bright line is the diaphragm, and here's the left ventricular cavity. It's important to remember that this view of the left ventricle is basically upside down from what you're used to. So this is the septum, but this is the anterior wall, the lateral wall, the infralateral wall, and the inferior wall. And here's a nice view of the left ventricle. This patient has flattening of the inferior wall. It's called a pseudo-infarction pattern because of pressure from abdominal contents during diastole. A short axis view of the aortic valve can also be obtained from the subcostal view. Remember that the non-coronary cusp is intersected by the intraatrial septum, making this the non-coronary cusp. And the right coronary cusp is the most anterior structure in the most anterior cusp. In this view, how do I tell what's anterior? Well, the pulmonary artery is the most anterior structure in the heart. So the right coronary cusp is next to the pulmonary artery, leaving this to be the left coronary cusp. Left atrium, right atrium. The tricuspid valve is here, although we don't see it very well. And this is the ostium of the IVC into the RA. This is the pulmonary artery. And you can even, with correct angulation, see the bifurcation of the pulmonary artery in this view. We image the inferior vena cava by shifting the transducer to and imaging the IVC and long axis, and asking the patient to take a sniff helps us estimate the right atrial pressure. If the IVC is a normal size and collapses fully, then the right atrial pressure is estimated as 3 millimeters of mercury. If the IVC is dilated, greater than 2.2 centimeters, and collapses less than 50% with inspiration, the estimated right atrial pressure is 15. And if either or is true, but not both, the right atrial pressure is estimated at 8 millimeters of mercury. Here's an example of a patient who has an IVC that's less than 2 centimeters. Here are the centimeter marks, and it collapses completely with inspiration. So we would estimate the right atrial pressure to be 3. You can also put an M-mode transducer, M-mode cursor through the IVC and measure the change in diameter with inspiration. And here again we see the IVC is less than 2.2 and it collapses more than 50%. So the RA pressure is 3. By angling the transducer, again, we can see the abdominal aorta above the feeder in this direction, so the bifurcation to the iliacs would be down here. And we also can pulse the abdominal aorta and get normal velocities and systole headed towards the feet. The final view in a standard transthoracic study is the suprasternal notch. The patient's head is extended slightly, and the transducer is put in the suprasternal notch. Again, this may be slightly uncomfortable for the patient, and you need to watch this. In this view, we see the aorta in long axis. This is the ascending aorta, the arch, and the descending aorta. The brachiocephalic vein overlies the aorta, and the right pulmonary artery is posterior to the aorta. By turning the transducer 90 degrees, we can see the aorta in short axis and the pulmonary artery in long axis. The brachiocephalic vein is over the aorta and then empties into the superior vena cava. The left atrium is posterior to the pulmonary artery in this view, and you can even see pulmonary veins entering the left atrium as the transducer is directed posteriorly. So here is a view of the ascending aorta with its branches, as well as color flow. The flow in the ascending aorta is towards the transducer. In the arch, it's kind of parallel, so we don't see flow. And then in the descending thoracic aorta, the flow is away from the transducer, and so it turns blue. And this is totally normal flow in the aorta. The branches are the left subclavian, the left common carotid, and the right brachiocephalic is usually in a different plane and needs to be imaged separately to be seen. Again, a great view for pulsing the thoracic aorta to make sure there's no coarctation. And so the sample volume here is put in the proximal descending thoracic aorta and the velocity measured. This is normal. There's flow during systole and then nothing during diastole. So it's our recommendation that all views and all measurements be performed in all patients, at least certainly for an initial study. And there are many off-axis views that you'll see in subsequent slides that may be required depending on pathology. Now let's turn our attention briefly to optimizing the images. And I'm going to show you some artifacts and some just bad scanning to make the point about adjusting the machine correctly and the views correctly. So here is a short axis, parasternal short axis of the left ventricle. And it's at the level here of the mitral valve, but you can see this very odd thing here. The ventricle isn't round. This, in fact, is the outflow tract. And it's because the transducer is not on we're not imaging a single plane. We're imaging kind of obliquely so that we see the left ventricular outflow tract and then the mitral valve and left ventricle here. Here the view's been cleaned up. The left ventricle is a nice circle, and we don't see that left ventricular outflow tract during part of the cardiac cycle. Here's what you can do with gains. This is the machine has been set with the gains way too high. This can happen if you're scanning in a very bright room and turn up the gains so that you can see, but then you will find when you transfer the images that you get this kind of snowstorm look. And if the gains are set too low, although the view may be perfectly on axis, this is uninterpretable data. You can do the same thing with Doppler. If we're trying to measure here, when we look at the Doppler that's set just right, the peak velocity is about 70 centimeters per second. Here, the scale is set way too small, so that 70 isn't even on here, and the baseline is in the middle, making it even less optimal for measuring velocities. Here we do capture the velocity, but notice that if we measure here or here, we're going to get a very big change in velocity since there's 30 centimeters per second between these two dots. And so we want to have the baseline so that the signal doesn't wrap around, and where we can measure the velocity correctly. The machine also has a wall filter. This allows us to clean up this signal, which is, remember I told you, very low velocity, high amplitude motion of the cavity's walls itself, rather than motion of blood within the cavity. Here the wall filter is set too high, so we're missing true lower velocities of the blood flow. Here the wall filter is set correctly. We get a little bit of the wall motion, but we can clearly see the entire spectral Doppler envelope of the red blood cell flow. We can do the same thing by adjusting scales incorrectly for color flow. The Nyquist limit is the peak velocity that color will resolve, and depends really on the depth, which sets the pulse repetition frequency. Here, the Nyquist limit is 15.4 centimeters per second, which is a very low velocity. So you see there's color all over this, and we really can't tell what we're looking at. The Nyquist limit in this image has been doubled, but we're still seeing quite a bit of flow and very hard to sort out. here's an example of appropriate Nyquist limit in a patient who really doesn't have, this is the same patient, but you can see that there really is no MR and no AR, but impossible to tell on those other views where we had so much color flow because of the inappropriate Nyquist limit. Now, not only can we make mistakes by setting the machine incorrectly, but we can also get artifacts. And artifacts are made because the computer misinterprets returning signals. Here's a patient who has a totally normal left ventricle, but if you look, it looks like they've got another ventricle right down here. Certainly we see motion of the mitral valve. This patient doesn't have two hearts. What's actually happening is that the ultrasound beam is coming from the transducer, and because the pericardium is so bright in this patient, more signal than the computer expects is bouncing off the pericardium, bouncing off the transducer, and returning again, so that the computer interprets that second returning signal, the one that bounced back and forth, as coming from a structure twice as far in the chest from the heart, and that's a mirror artifact. We also can get reverberations. This you'll recognize as a subcostal view, IVC, right atrium. Here's the aortic valve, although not well seen, and the pulmonary artery. This patient has a pacer wire in their right ventricle, and we see all these lines hanging off the pacer wire. This isn't, they aren't actually there. It's because the pacer wire is so bright that it's sending a signal back to the transducer, and the computer's misinterpreting that returning signal. This is a shadowing artifact. This patient has mitral annular calcification here. Here's the left atrium. Here's the descending thoracic aorta. And the calcium reflects all of the ultrasound that's beamed to it. And so nothing penetrates below it. And so we see this shadow artifact moving back and forth right behind the mitral annular calcification in line with the ultrasound beam here. And so there isn't really a hole moving back and forth. This is the computer misinterpreting the ultrasound returning signal. There's no returning signal from back here because of the reflection off the mitral annular calcification. This is a lens artifact, very common in the subcostal view. This patient looks like they have two aortic valves and two interatrial septums. The real one is darker than the artifact, and this is from the ultrasound beam being refracted through a lens, usually the liver, causing the two signals to be misinterpreted again by the computer, and the two aortic valves placed side by side. And finally, not the greatest example, but this is a side lobe artifact. These lines coming from the mitral valve calcium in this patient seem to be going sideways, but these are really discrete points. This side lobe is the side beams of the ultrasound signal picking up additional reflections and putting the pictures into the left atrium. We'll have a better example of this in the physics slide set. This is a common artifact and often can be confused for a dissection flap if you have a very bright side lobe artifact when you're looking at the ascending aorta. So there'll be more about optimizing images in the physics slide set, but remember, besides getting the right views and the right timing, it's important to be able to troubleshoot the image to improve the quality and diagnostic value. Artifacts are often very predictable and move independently of the heart. They cross tissue planes and so can be distinguished from true cardiac structures. And thank you very much for your attention. Have a great day.